Hi, everyone. I am Krista with Relivar Home Care. I'm the administrator, and I'm here with Misty, the owner, today. And then we also have Angela from the Hospice of Michigan company. And she's with us today to provide a training for hospice and palliative care. I know that caregivers have to deal with hospice and palliative care a lot, and sometimes it is difficult to understand the differences. So Angela was nice enough to come on with us and give us some more information for our caregivers and anyone else who wants to listen in and understand better. Hi, Angela.
Hi, Krista. How are you?
Good. How are you today?
I'm well.
Hi, Angela. We're so glad you're back.
Oh, thank you. Good to be back.
Yeah.
Help make some decisions for people a little easier between the hot topic of hospice right now and palliative. Since we're seeing it so much more in the community, I think it leaves even more questions to families about what it actually is and what it can do for them.
Definitely.
Yeah. So I think, well, let's start talking about palliative, since that palliative is a program that right now is provided to people in their home, and it is covered under your Medicare. But palliative, you really want to look at it as a specialty program, such as your oncologist, your cardiologist, except palliative's focusing on what we would call end-of-life care. But when we say end of life, what we really mean is simply you have lived out more of your life than what is in front of you. So these are people who generally, they may have chronic illnesses such, let's say, congestive heart failure, dementia, COPD, and they find themselves going in and out of the doctor's offices, not so much for an actual visit, but for medicine checks, because they haven't quite found yet the medication that gives them the best decline in symptoms that they're having. And those symptoms would be something to look for, would be anxiety, depression, no appetite, nausea and vomiting. And pain is usually one of the biggest that people will want to talk about. They've gone through multiple medicines. They're still not seeing enough relief that they find a place of comfort. When you're noticing you're spending more time at visits regarding medications for these symptoms, that's where palliative would be a great benefit to somebody. And palliative is something your physician does not have to order it. You can reach out to a company yourself, and then they will make connections to get parts of your chart to help work with. And for our program, for our palliative, we are nurse practitioner ran. They are going to come out and see you. And after they come the first time, it's then that they'll determine how often you really need their care. Because remember, you'll still be seeing your regular physicians. So she's not taking over all of the care, just the specific symptoms that need better control. So her visit might be only once a month so that she can give time trials to the medication changes they're making. Where some people even, they only need a visit every couple months because they start to do much better once they find the right medication combo for that person. And along that way, as she's working on controlling those symptoms better for you, she's also going to having conversations about advanced care planning, because this is a great time to start doing your homework about what next. We always think about it as when we see people come in the hospital and there's a really hard situation occurring, they ask you to make big decisions. What is your thought about end of life? You know, do you want a do not resuscitate order? What would you want? And people find themselves having to make that decision very quickly. So instead, we want to come in earlier so we can start having conversations over time and really get all those answers you need to make the best decision for you, instead of being put in that situation of having to make a quick choice. Right? So palliative care, it is a great program for people who, whether they're still in their own home, independent living, assisted living. And even at our skilled facilities, you'll see people utilizing that service. It covered in your Medicare and many insurances for people without it. So that's a great place, I think, to start looking once you notice you're spending a lot more time in those doctor's offices than not.
Yeah, that's good to know, because I feel like having to make quick decisions like you were talking about in the hospital or something like that is not for everyone. You know, I mean, a lot of people have to process, and that's a big decision to need to know right away.
Yeah, that really is. I think that is the biggest decision you're going to make during your healthcare journey. And there's so much misinformation out there for people. And unfortunately, that gets shared much more with them. So when the time comes, they'll question themselves after, was that the best choice for us?
Right.
I think, small conversations started earlier, I think it really helps prepare you for at that moment and to feel good about the choice you have to make.
Right.
Angela, I have some questions.
Yeah.
As well. Do you have to be homebound?
You do not. Not at all. Very often, they're still living their best life they can.
Okay.
So being home is not a requirement at all. In matter of fact, if we're able to get those symptoms under better control, it's that much more living they're going to get to do outside.
Okay. And, some folks think like, oh, once we start talking hospice, they think about, oh, I'm dying. And then you're trying to explain to them palliative care, well, no, that's not, what we're talking about here. Do you have any suggestions or recommendations for how we work through that with a loved one?
Definitely. Palliative, right away I explained, because it is that fear of, you're telling me I'm dying. We're not telling you that. What we're telling you is, we think you have some symptoms that are what are causing you bigger problems than your actual illness you have. So let us step in to take care of those, so you can still enjoy your days. You still have positive experiences. It is not about end of life at that point in the terms of you're dying soon. So we want to continuously stress that to them. It's about getting out there with better days. And I've noticed when you are talking with somebody, you have to be very distinct between the two programs. You don't want to intermingle them at the same time. That is where they do feel overwhelmed with that choice.
Okay, so just really stick to only talk the word palliative and don't allow hospice to come in on the conversation.
Yeah, I think that definitely helps them clarify. And then farther down the line, when we are seeing, unfortunately, a decline enough to think about hospice, again, you start that conversation slowly, because at that point they have a little more knowledge, understanding where they're truly at, and we work with them to guide them.
So would you say something like, palliative care is going to help you manage your symptoms from your disease, whether it's congestive heart failure, COPD, or whatever chronic disease they have?
Yeah, absolutely. Yeah. Okay. Palliative focuses solely on those symptoms being managed better.
Okay. And, and what can they expect if, for example, I know you said, well, a nurse practitioner, but, why palliative? It must have some form of results out there that produce some form of results and help the folks. And why is it that, companies like yours can do this when someone going to the hospital or to their doctor all the time can't seem to settle that down?
Right. I think a big part is, for a lot of people, when they tell you they're going to the doctor's office, the look on their face is usually that of, gotta go to the doctors. And the more time you're spending in them, I think you become a little more fearful of each visit. It takes a lot on, especially as we're aging. It takes a toll of having to get somebody who is, if they're having ambulatory problems, getting them to that doctor's appointment. And then the stress of who has to take off work to help them go? Because I should probably go so I can hear what the doctor's telling mom. Where when we tell them palliative, the biggest part I find that is beneficial for people is you're at your own home. Your nurse practitioner is coming to your house where you're comfortable. This is your safe zone. And she is focusing solely on you with no other patients waiting for her. You have her undivided attention.
No distractions.
In your house. Yes. I think that way they can actually sit there and have that full conversation without the knock on the door or worrying about, am I keeping my doctor too long? Because people try to be courteous, of course. So knowing you have your own person right there, she's there as long as you need her, that makes a difference, I think, in how they respond and work with that nurse practitioner.
I can understand that because I can tell you, working with my own folks, you know, and my mom goes to the doctor and I'll say to her, did you tell the doctor that, you know, whatever she's having, issue she's having? And she's like, no, I didn't want to bother the doctor with that.
Yes.
Like,
yes. Or they get, before they go, they're telling everybody about all these things they're experiencing and they get in that room. How are you? Okay.
Fine. Yeah.
Any problems? No.
right.
And it's not that they don't want to share. I think it just, all of a sudden they're just frozen.
Yeah.
And they walk out to the car and all 50 questions pop right back in your head.
Yeah.
Yes. That happens to my grandma every time she goes. You know, she'll tell me, I'm having this, I had that happen, this is going on. And then you go to the doctor and she's like, everything's great.
Yes.
Like, but it's not. You have to talk about what's happening, you know, but they kind of panic, you know, like,
yes.
I'm in this situation. I don't know how long I have, like you said, I don't want to take up his time. I'm a burden is, you know, what you hear a lot of. And so, but they can't take care of it if they don't know.
Exactly. They're basing that doctors, his whole care plan is based on what you have shared with him. So he can't address and fix what he doesn't know is broken.
They're not mind readers. They're very bad at that.
Yeah, we don't have that skill down yet. I encourage even very young people, my own adult children, I encourage them. When you know you're going to the doctor, a week or two before you're going, keep either in your phone in your notes for them, or if you have just a piece of paper, index card. And every time something strikes you in your head of, oh, that's really been bothering me, put it down there. Take your notes with your phone or on your index card, take it to the visit and hand it to him. Or if you want to read it through with him, read it through. Even if you forget a couple, at least you have addressed some of the things that are going on. So I think there are ways to help if they're willing to.
Right.
So question then, what do I lose? Like, do I have to give up my doctor? Like, I don't go to my primary anymore. Your folks, you know, like the nurse practitioners would take care of things from that point forward. What about my specialists, like the cardiologist or, you know, pulmonologist? What happens with them?
With palliative, you're not going to lose any of your current physicians or physicians you want to see. That nurse practitioner is simply jumping in to your care team. She's now going to be a part of that. She's there to actually support all those other physicians for that symptom management. And she will make connections with those offices because, of course, she wants to make sure her plan and her changes are cohesive with what their care plan is for you. We're there to support them. We're another layer of support.
Okay. All right, great. Thank you.
Yeah. So if we go over to hospice, like palliative, does focus on symptom management. That is definitely the base of hospice. But hospice can only start when a physician, if he looks at your medical journey at that point, feels you have a terminal illness, that if it continued to progress the same way it has, you would have 6 months of life left. That sentence scares families and people very quickly for a good reason.
6 months is not a long time.
No, it's not. But what we don't have written down is the fact that when we talk 6 months life expectancy, we're referring to a textbook case. Fortunately for all of us, none of us are textbooks, and we could all have the same disease, and it's going to run its course very differently for each one of us. So some people with an illness, unfortunately, they may only have that 6 months or less. Others with the same disease, they might have a year, 2 years, 3 years, 4 years left. They're still terminally ill, and they are having small declines, but not nearly as fast as the other person. They would still be eligible for hospice. And actually, we know the sooner hospice can start with somebody, they have more quality days in front of them than without the hospice.
When you say decline, what are some of the things that they look at for hospice, to have them qualify for that, or what has to be kind of changing for them?
Sure. Once they're on a program, their nurse case manager, she is looking for changes in appetite. Weight loss is a large picture. Increase in pain. It could be respiratory changes. Their activity level is decreasing now. Before they were getting up, they were going to the grocery store with their family. Now they're not leaving their bed. It's a change in that quality of life, what they're able to do.
Okay.
So that is first to get on the program with any hospice. And hospice is a Medicare benefit. So regardless of what company, there's many companies to choose from, but regardless of what company you choose to move forward with, we all have the same eligibility guidelines we must meet, which I think that makes hospice a stronger program, because they lay out, you must offer certain things through their program.
You know, Angela, it's interesting that you say that, because I've dealt with so many of them, and each one, even though those guidelines might be the same, they all look at those guidelines differently.
Oh yes, interpretation is everything.
Yeah. So in a situation where someone might qualify under your company, they might not qualify under another company, or vice versa.
Absolutely. When you look at eligibility, it takes 2 physicians to agree that they have 6 months of life or less left to be eligible. So generally you'll have that person's, it may be their oncologist or their primary care physician. And then the hospice physician also has to go back and review all your clinicals, that information, and make that determination. And that's where those opinions, they can vary. Of course they can. You know, once you're on hospice, there is what we call a research time that happens at designated points. And that's where we're looking to make sure, has there been that slight or bigger decline? Then you can stay on hospice. So again, longer. If we're not noticing a decline, that's where you hear people graduate off services, where actually we tell them, you're doing too well for hospice. This is a good day. And then we work with them to reconnect with their physicians they were seeing before us.
Are there situations where, when you're on palliative care, you could have the same thing happens, where they have to come off because they don't qualify any longer?
Definitely.
Okay.
You know, if they are able to find a good medication that they're responding to, we've given it some time to see that it's continually doing that. Yeah, they will talk about at that point discharging off. A lot of times, whether our nurse practitioner or counterparts of mine we don't want to just tell them you graduated off, thank you, goodbye. No, we'll ask them, you know, here's where we're at. This is what we need to do. Can I check in with you in, let's say, in 1 month? Because we do want to let them know that line of communication. We are here going forward. If you have any questions for us, if something's changing, please, we want to make sure they understand we're still here for you. Let's talk, call. So we'll set up with them some checkpoints so that we can continue to be there.
Okay. And is palliative care a Medicare benefit as well?
Palliative is. With palliative is covered under your Medicare Part B, where hospice is covered under Part A.
Okay.
So with palliative, if you have a copay when you go to any of your specialist doctor's appointments, you would have that same copay with palliative. Where hospice with your Medicare is covered 100%. And that includes all your nurse visits, your home health aide, a social worker, a spiritual care advisor, our hospice physician, and then also volunteers programs that will be there to help you too.
That's great.
Yeah, I think that's good.
The supplies that you know, because I know under hospice, they get additional supplies.
Yes.
Like briefs and all that.
Yeah, all your briefs, which we know for families, if they're using their briefs, that's a large expense.
Yes, it is.
So hospice will cover them. They're also covered completely, delivered to the home. All of your medications, and whether you need a hospital bed, a wheelchair, any medical equipment is covered under the benefit and brought to you. And
but does that vary from palliative?
Greatly. Unfortunately, palliative is not a regulated program under Medicare yet. So there are no guidelines of what we must provide. So they will cover the nurse practitioner or your doctor, but no, the medications they do not, and the medical equipment they will not cover.
Okay.
Yeah.
That's helpful. Thank you. Because, you know, once you if they need a hospital bed or a wheelchair or medication, that really takes a burden off of families for paying for those costs.
Oh, immensely.
Yeah.
You know, by the time somebody is to the point where they are in a position for hospice, they've already had an illness for quite some time generally. And you find at that point financially, they're quite depleted on navigating that. So that is a big, I think at that time, the family can really, a little sigh of relief at that moment. They can breathe a little better knowing.
Right.
Yeah. Right. So I think hospice, people, because they hear the word, they fear it, they want to wait. But we really, as a community, we need to talk more about hospice. We need to bring out the program to them. Because if somebody waits till you are in the hospital and at that point, the doctor are telling you there's only days left, hospice will make you comfortable. That is always what we're there to do. But that will be it. Where the whole program, the sooner you come on, we're going to take care of the person who needs hospice, but we're also there for support for that family. And after the passing of their loved one, we stay on with that family. And that's the part I think a lot of times people miss out on because they wait so long. You know, if you let hospice come in sooner, that health aide, they're coming in and out of your home caring for your loved one. That allows the spouse or the children to take some time to step back and be able to let someone else be responsible for a little while. They need those breaks. And of course, it's a free benefit to use it. A social worker, they're there to support that family, help you navigate through any paperwork you're having challenges doing or that you don't know you need to do. They'll help walk you through that. And of course, they are there to listen, to navigate any waters that are troubled for the family. And after then, the grief program that stays with that family, which is the free counseling, whether they choose to do it one-on-one with our grief counselor, or they can join one of the support groups in person or on Zoom, multiple ways they can do it. But it's there to help support them, including the children's program. So it's quite large.
Well, and I would say, we have worked with your company, Hospice of Michigan, quite a bit. And we like the fact that really this is all that your team does is hospice. Yes. and palliative care, because not all companies do palliative care.
Nope.
Right. And you have great staff. They're well trained. You have an on-call team. available for families if they're in a crisis. That those are all wonderful things. And we find, I think the major thing is most families do not recognize, like, let's take a look at hospice. And many times the doctors, they don't recognize it either.
No. Physicians, there are some physicians in the communities who are great at having end of life conversations, but there's even more who are not.
Right.
For some, they've had this person as a patient for many years. They have created this friendship bond between them. How do I tell them there's nothing more I can do to help them? It's a very difficult conversation, understandably. They don't know how to start it. Some physicians, they want to try that one more thing to see, will it help them? End of life is not any easier being the physician to be able to tell the news to. Mm-hmm. It's quite often we'll get that phone call of, will you go have that conversation with them? And of course we will. It's a conversation we have regularly. I don't look at it as heavy and being this doomsday deliverer. Instead, I look at it as an honor that you trust that I can help guide them and support them to make the hardest decision they're going to make for somebody they love.
Mm-hmm. Oh, absolutely.
And I can, if it takes 3 hours of sitting with them, they have my 3 hours of undivided attention. Ask those questions, let's talk. Where we know the physicians, they have to keep going.
Yeah. Yeah. Well, I know one gentleman I met with recently under our care management program was 97 years old. And, my goal is typically, let's just set the appointment for you guys to meet with them, because first of all, we don't even know if they qualify. But really, there's nobody else that I've found that are better at talking about it and explaining it than, your team, your folks.
Oh, thank you. No, I know when we do onboard new employees, a lot of times we'll get asked, could you sit down with them and show them how to have that conversation? I can tell you very honestly, I can't tell you what my conversation is because it's very unique to every person I'm meeting. Mm-hmm. It can't be a blanket conversation. It cannot be about statistics. I need to know who it is I'm talking to. I need to know what their journey in life has been, where their adventures have led them, their beliefs. Right. These all have to be taken into consideration to know what it is to them that's important and how best we can support that. So each conversation, it's always very different.
Yeah, and I have to say, this gentleman who was 97 that you guys went and met with, his, well, we call them hot buttons, but his hot button, and the reason why he agreed to sign on is because he was going to get all his supplies paid for. It was going to save him money, So originally he was saying, I'm not going to die. I'm not dying, but then he's like, oh, you're going to pay for all this stuff? Well, that's wonderful. And you're going to come and visit me, and I'm going to see nurses regularly. And, all of a sudden it was like, oh, okay. And I don't have to die in the next 6 months. So it's pretty good to me.
And it is funny how many that is. What makes them go, oh, this is good. The fact of, wait, we're saving money.
Right.
You're like, okay. And at the end of the day, we will hear at times, don't tell mom, she doesn't know. People don't. Mm-hmm. You don't have to say it. They know. The bigger conversation part is, what do you want to do going forward? Right. That's what I need to know. I don't have to tell you you're terminal or you're on a decline. You already know that. Mm-hmm. Let's talk about what you would like to see going forward. The first great grandbaby coming in the family. I want to hold that baby. My first grandchild's getting married. My child is graduating from high school. My child's graduating 5th grade.
Right.
They all have different goals, as they should. So at that point, how do we support those goals? How best can we give you an opportunity to see those milestones if possible? That's what our care team is going to rally around and find ways to support. They don't need us to focus on the end of the journey. They already know what it is.
Right.
So let's stay present and still bring them quality of life so they can see these events. And that's where you'll see a whole different response from a family and the loved one.
Well, and we did have one client, and I know we talked about this before, that had utilized the services after his wife fell down the stairs. She had dementia and had a fracture. I forget where the fracture was at, but it was a serious fracture. Had she, what was it?
Her back.
Her back. Had she remained on that path, because the hospital could not, they weren't good at managing her pain, that if she stayed on that trajectory, she probably would have passed away. However, she went on hospice to help manage that pain for 6 months, maybe 8 months, and came off, and she was perfectly fine. It allowed the fracture to, recover, and it was amazing to see that happen. So I think sometimes people don't think about that as well.
No, yeah, they don't. They really don't. And we see it. We see it. Do we see it daily? No.
Right.
But will I see it monthly? Yeah, about once at least. And it's a lot. The thing we contributed to is, up before hospice, they were going in and out of the doctors multiple times. They were going to therapy over here. How many ER visits were there? That is absolutely draining, extremely stressful, increases their anxiety. You're just accelerating all of the negativity around their health.
Right.
Once they're on hospice, you mean I'm staying at home, wherever that is? Your nurse, I have access to her 24 hours a day. The hospice physician will come visit me whenever I ask. I have health aides coming to bathe me and help straighten up my room, take care of me. All this new attention they're getting in their place, you start to see them, I'm hungry a little more now. They start eating a little more, a little better. Their overall demeanor, the anxiety's coming down some. Depression, it's coming down some. And all of a sudden, they're flourishing again. Does that mean they don't have a terminal illness anymore? No, they still do. But what it means is we've greatly been able to slow down that process for them to have some more quality days out there.
Right.
And when that does happen, again, before we graduate them off service, we've already contacted their primary care physician, scheduled that first appointment so they can be seen right away when the change happens.
That's great.
And then we stay in contact with them. At first, we'll give them a call for a couple months, at least once a month. And then after that, families will either say, please keep, or, I think we could, push it to a call every other month, or whatever it is that they feel comfortable with. And we stay there just so they know in the background, any questions, any problems. When there is another decline, unfortunately, it will come. We're still here for you. But right now, enjoy this time. Enjoy the present you've been given.
Right. I love the word that you use, which is graduated, when they've graduated off the program, because, sometimes they're like, I'm on it and I'm going to head to the homeland, and it's not really the case. No, if you get better, which is okay. And we're actually happy that occurs, by the way, that's a good thing. I can tell you, from an incident with my own mom last year, she had to go to the hospital for an upper respiratory infection. And, when I was talking to her in the hospital, she said to me, well, I didn't want to come in here. I hate coming in here. And, before I left for the evening, I said, well, then that's a different conversation, Mom. If you, let me honor your needs where you're at. Okay, because if you don't want to go to the hospital, and that's okay, this is your life and it's your choice, then we stay at home and we find the solution with you never going back to the hospital again. And if that's what you want, then that's what we do. And I went home, to their house, and then I went back to they live in Florida, but then I went back to the hospital the next day, and she looked at me, she goes, I'm really sick, aren't I? I said, yes, you are. You are very sick. So, she did end up getting better, but, I think it's so important for family members, because we see a lot of that where they're pushing them, eat more, and you got to take this, and you got to do this, and we got to go to the doctor, and we got to go to the hospital, and we don't. No. If we meet them where they're at with their needs and their wants, isn't that what everybody would want?
Oh, absolutely. Whenever the topic comes up, especially with food, I'll tell families a lot of times, we're the chicken noodle society. The kids had a runny nose, we made chicken noodle soup. The neighbor had surgery, we take over a casserole. We feed. That's what we do. We feed people when they're ill or down. Unfortunately, when the body has already started communicating inside itself saying, I'm sick, it's time to start slowing down. We're going to start our decline. The brain starts sending out a message to each organ at a different time. Hey, you don't have to work so hard right now. You can cut down your energy a little. Okay. And then it will go to the next organ, tells it, slow down a little. And as each of them are slowing down, that need for food, they're not hungry. And one of the worst things we can do for somebody as that change is happening, as it's going farther along, is to start force feeding them, because that is when we see people going to the ER for aspirating.
Oh, yeah.
And that's not the end you want for your loved one.
No.
So, and it's hard because our whole lives, food is what we celebrate with. Food is what we feel better with. So changing that thought process, it is very hard. I've had people say to me, I feel like I'm starving them. I feel like it's cruel. And I can understand why they feel that way. But that's where we just have to keep educating and explaining. Where some people, they never lose their appetite. They want to eat Snicker bars every day, all day. It's the end of my journey. I couldn't eat like that before. If it's safe, beautiful. Eat that Snickers bar every day. It's what can be done safely, and to them, what does matter.
Yeah.
In hospital visits, it's not often you meet someone who says, I love going back to that ER.
Right.
You don't hear it. The
right.
thought, it surprises people that majority of hospice is provided in people's homes, and that we can safely and with great pain control keep somebody in quality life outside of that building.
Yes.
That's really hard for them to understand. But hospice has been around a very long time. We've had a lot of years to learn more and how to do it better. And we have. It's all about that compassionate ending.
Yeah. And I want to just touch on one thing, because from a care manager standpoint, when we recommend it for our folks in a community, because so many of the communities are still so very short-staffed, or you don't get the attention that you need, that when we bring in hospice and you've got that same aide every single week doing the showers twice a week, you got that same nurse coming into that building 3 times a week and checking on your mom or your loved one. I mean, the level of care just goes up exponentially, and better communication, because, you're dealing with the hospice nurse directly who's visiting your mom or your loved one 3 times a week or twice a week, or depending on what it is. They're in that building all the time. So if they're close to being able to qualify, it would be a wonderful thing for you to add the service, because it increases the quality of care.
Definitely. A lot of times they'll understand hospice can happen in that facility. But then they'll ask us, but why do I want all those care team members to come? And you just laid it right out. The more hands in, the more eyes on your loved one, the better care they're going to get. You know, the facility health aide, she has a lot of patients.
Yeah.
She has a lot of residents she has to take care of. She's doing her best she absolutely can. If we know we have more than enough health aides, why would we not partner them up there? I think it's appreciated on the facility, and it just can only benefit your loved one.
Yeah, because, you know, when you look at these communities, they'll have one nurse for 40 or 60 residents.
Yeah.
So, you know, if you have your hospice in there, they're checking for edema and they're checking for wounds, and they're, you know, they're dealing with things quickly with the physicians, you know, instead of a delay with the, you know, physician on staff or the one, you know, if they go outside. But, you know, it's such a tremendous service that you guys offer.
It's really, you know, facilities have always had a challenge because of what they are. That it's hard work what they do. But we like everything else now after COVID, they have the same problems every other business does, finding staff. Mm-hmm. They're not exempt from that problem. It's very pronounced in all facilities. And I don't know of any that don't have signs everywhere asking for more staff. They're looking, but they're just not out there right now. So while they're working hard, they're overstressed. They're doing their best every day, but we know they can only do what they can do. Yes. So yeah, let's support each other. We have to jump in.
Right. So just to kind of wrap this up, unless you have something else that you want to add to this, anything else? Okay.
No, I think that's a really good base.
Okay. What I want to do is just, you know, kind of direct this back to family members and say, you know, a couple of things that you said is if you're seeing it, you know, a decrease in appetite, you're seeing increase in pain, you're seeing weight loss, changes in respiration, decreased activity level, one or multiple of those issues that you're recommending at that point to at least put the call out to talk to your team, Hospice of Michigan, and, you know, see if it makes sense for you guys to come out and meet with them to talk through further, you know, whether it makes sense to get them on palliative or hospice care. And you guys will actually help guide them through that process.
Oh, definitely. Yeah. It really, it's much better to call too soon than far into the journey, because then we have the opportunity to share with you all the checkpoints you want to be keeping an eye on, what they have reached, and we will continue to follow with you.
Okay. All right. Well, Angela, you're awesome. Thank you so much. And again, Angela is with Hospice of Michigan, and you cover a large variety of areas. Is it all of Michigan now?
We cover from the Mackinac Bridge down, yes.
Okay, so all of Michigan, and it's the only thing they do, and they do it really well. So if you're looking for a good company, we highly recommend them. So thanks again. It was great talking to you.
Thank you. Thank you so much for letting me join you guys today. Greatly appreciate it.
All right.
Thanks.
See you later.
Thanks.